I want to extend my welcome to the wonderful audience that's gathered here today. I'm Dr. Peter McCullough. I'm a practicing internist and cardiologist in Dallas, Texas, United States. I'm an Irish American and proud to be so. I wish I could be with you right there. I have relatives in the wonderful island of Ireland. And I can tell you that at this point in time, I have a deep concern as well as compassion for those who are vaccine injured, and recognize that there now are about 15% of all people who've taken COVID-19 vaccination that have some form of injury or new medical problem they're dealing with. That's fully 15% as determined in a survey by Zogby and Company in the United States. Beyond the serious syndromes of blood clots, myocarditis, and neurologic injury that requires subspecialty care, a lot of the vaccine injuries that I've been following in clinic, including headache, ringing in the ears, numbness, tingling, various forms of rashes, weight loss, hair loss. After following these individuals now for nearly 2 years, it's been my observation that vaccine injuries do progressively get better. The body heals over time. It takes effort, physical conditioning, excellent diet, nutrition, and attention to self-care to help on the pathway to recovery. There is no cure or medical treatment for these types of vaccine injuries that we found at this point in time. Preclinical research is encouraging along specific lines, and you should bring that up with your doctor. But I want to point out that it will get better, provided no additional injections are taken. I hope everyone hears this. We cannot continue to take injections of messenger RNA or adenoviral DNA and keep the body healthy. It's impossible. These injections are long-lasting genetic code that produces an even longer-lasting foreign spike protein that's causing the symptoms in those who are vaccine injured. So we have a strong call to action to decline any further vaccination and head on the road to recovery.
How do you interpret cases of sudden death when there's no preceding record of illness?
Cardiologists have been tackling the issue of sudden cardiac death for decades now. And in the era prior to COVID, the leading cause of sudden cardiac death was actually myocardial ischemia, or a heart attack that precipitated ventricular tachycardia, then ventricular fibrillation, and then it progresses to asystole, or a flatline. And that's the progression of sudden cardiac death. And it was so important to understand that if we could stabilize coronary artery disease, if we could intervene, the advent of coronary care units, out of hospital resuscitation, these were these big advances that we had in clinical cardiology. But since the COVID-19 era has occurred, and we're now finishing our third year of it, everything has changed. The epidemiology of sudden death has changed, and reports from Israel indicate that there's a large wave of sudden cardiac death occurring in young people in their 20s, 30s, and 40s. And then there's a confluent literature that COVID-19 vaccination, messenger RNA, adenoviral DNA, or even the antigen-based vaccines cause a syndrome called myocarditis, or heart inflammation. And what we know here is that heart inflammation can result in irritability of the myocardium and precipitate ventricular tachycardia acutely and start this progression to sudden death. But it also can be more insidious, where there's a scar formation in the heart because of the inflammation. And that scar is indolent. It's not symptomatic until, at the right conditions, there is an abnormal depolarization of the electrical signal across the heart with a heartbeat. And that kicks off ventricular tachycardia and into this sudden cardiac death syndrome. So there are now some very important papers that have come forward. The first one was New England Journal of Medicine by Verma and colleagues, where there was a report of someone who died after messenger RNA vaccination, and the death was due to myocarditis. And there were autopsies demonstrating inflammation in the heart. Then a paper from Choi in Korea caught my attention, a 22-year-old man who was 5 hours after the second injection of Pfizer, and he dies in a Korean hospital 7 hours later, despite all resuscitative efforts. And the Koreans did an autopsy, and they found massive inflammation in the heart, destroying the conduction system, the heart muscle. It was a fulminant case. No, there's absolutely no doubt about it. These are in the peer-reviewed literature. And the third paper that appeared was by Gill and colleagues. And I think the Gill paper is very notable. And this was published in Archives of Pathology. And what happened here is 2 boys, ages 16 and 17, were found dead in bed by their parents at home separately. Each boy had taken the second Pfizer injection on days 3 and 4, respectively. And the Connecticut coroner conducted an autopsy. And he called in pathologists from University of Minnesota and University of Michigan for examination of the histopathology and the hearts. And they concluded together that the boys died of COVID-19 vaccine-induced myocarditis. It was published in Archives of Pathology, one of the best pathology journals. And so I think the Gill paper brought the issue forward that, in fact, death can occur with myocarditis with no antecedent symptoms. And it can be considered subclinical. That is, there is heart inflammation going on, and the young individuals don't feel it. And the first manifestation can be sudden death. And then the final paper I want to cite is by Patone and colleagues, and it was published in Circulation, our best cardiovascular research journal. And this is from the United Kingdom. And Patone is reporting 100 cases of fatal vaccine-induced myocarditis in the United Kingdom, where vaccine-induced myocarditis is #1 on the death certificate. The clinicians have made this determination. And there, about half the cases are with messenger RNA vaccination, Pfizer and Moderna. And then the other half is with adenoviral vaccination, that being AstraZeneca. So the important points of the Patone paper is that this risk is not isolated to messenger RNA vaccination, and the numbers are large. And if 100 is published in a case series, the estimates are the real number out there could be substantially larger. There's what's called an underreporting relationship in all the case series and in all the safety data, because other events happen and they're not clinically recognized, or they don't get into research databases. So from these autopsy studies where we have clear histopathology, there's been a closer examination of people who survived, and that was by Bohmeyer and colleagues in Germany. And Bohmeyer did biopsies of young men who have myocarditis and found the spike protein, which is the antigenic protein that's produced by the genetic code that's injected. It was right in the heart muscle. So it was clear that the spike protein was causing inflammation. And this is a very concerning set of observations in the peer-reviewed published literature. And the question has come up, how often can this possibly happen? What is the universe of risk here? 2 recent papers have weighed in on this. The first one is by Mansugian and colleagues. It was the first prospective cohort study. And a prospective cohort study means that there's a set of scientific measurements made before the vaccine, and then a set made afterwards in everybody. And in this case, the setting was Bangkok, Thailand, but they used state-of-the-art Roche troponin assay, which is a blood test for heart damage, did echocardiography, ECG, and when myocarditis was suspected, they did cardiac MRI, which is a gold standard. So this is a study that's of the highest quality. It could be done in any UK or United States center with the same equipment. And they studied children aged 13 to 18 just before and after the second injection of Pfizer. And what they found is that 2.3% of the children developed myocarditis. 2 children were hospitalized. And importantly, more than half, it had no symptoms. So it was asymptomatic. So we now understand this subclinical myocarditis is a substantial fraction, and we know the number is quite large. If we were to extrapolate this, this would be 23,000 cases per million. The background rate of myocarditis due to parvovirus and other causes before COVID is 4 cases per million. So this is a large increase in the myocarditis cases that would be expected from mass vaccination. And then a paper just presented at the European Society of Cardiology, our best cardiology research meeting, was by Lepesek and colleagues from Basel, Switzerland. And they studied 777 healthcare workers, measuring a high-quality troponin assay before and after the third vaccination of the booster messenger RNA vaccine. And they found very similar results, 2.8% rate of a characteristic rise and fall in cardiac troponin, the signature of myocarditis or subclinical myocarditis. So putting all this together, we can expect now a large fraction of individuals who are going to develop myocarditis. In the published epidemiology by Rose and myself in 2 separate papers, 90% are men. When it's symptomatic, hospitalization is warranted and we can begin medical therapy. But I'm greatly concerned about the half of individuals or more who have no symptoms, and the first manifestation may be sudden cardiac death. And the risks, as the Lepesek paper points out, may be cumulative with successive injections of messenger RNA or even adenoviral DNA vaccination. So the teaching points that I've learned from a cardiovascular perspective is that the only way to reduce the risk of myocarditis is to decline vaccination. And so I think that's very prudent. One can't recover the heart damage, and not all of the sudden cardiac arrests can be resuscitated. And it's simply not worth the risk of losing a single life with COVID-19 vaccination, because it's a readily treatable illness. The virus is mutated to a far less lethal strain, and we have better strategies to handle this. And to give reassurance to the audience listening, a recent paper by Chin and colleagues in the New England Journal of Medicine at the end of October studied 59,000 prisoners and 17,000 staff in a congregate setting. And they analyzed what's the real risk of hospitalization and death when someone's already had COVID and now they're having a second or third case. And the answer is the risk is negligible. And specifically in that study, the risk was 0, and it didn't matter if any vaccinations were taken or not. So I feel very confident that the risks of COVID-19 vaccination on the issue of myocarditis, and even that condition alone, far outweigh any benefits at this point in time in the COVID-19 pandemic. We can drop all vaccine mandates, and I think from a safety perspective, we can pull all the vaccines off the market, let people in the United Kingdom, Ireland, United States, across the world return to normal, and then let's stay watchful for signs or symptoms or even any premonitory signals that there could be subclinical myocarditis left. Myocarditis now, in my view, is a much bigger concern than even the COVID-19 pandemic itself. I'm Dr. Peter McCullough, practicing internist and cardiologist in Dallas, Texas, and I've been a regular contributor to the medical literature, as well as in the media and US Senate and state Senate testimonies as a COVID-19 expert. Thanks for having me on the program.